next we're going to go into vertebral augmentation, which those of you who have been following the literature and the WWF know is a pretty interesting aspect of what we do based on both clinical practice and on published studies. And so we're going to start out with Izzy Lieberman presenting on a comparison of vertebral augmentation procedures.
Thank you, Randy. I'd like to talk a little bit about the comparison of vertebral augmentation procedures. We know that compression fractures are insufficiency fractures of the spine. It's osteoporosis. My hope is that in the next 10 to 15 years, osteoporosis is going to be a historic problem because we know so much more about it. Public education is much better now. People are supplementing with calcium and vitamin D. We've eliminated a lot of the risk factors for osteoporosis in the general public. So the next generation of women and some men hopefully will not have to suffer with hip fractures, distal radius fractures, and spine compression fractures. We know it is a huge, huge problem. We all see this in our clinic. We all see these elderly women and some men come in compressed down, and apparently 750,000 per year in the United States right now. And we do know, and this is all documented in the literature, we know that when you have one compression fracture, you've got a 5-fold or 20% risk for an additional compression fracture that same year. So why are we not listening and reading and paying attention to these results that are out there? And they're all in very well published studies done over the years. We know the consequences are the pain, the height loss, the impaired function, the quality of life issues, the pulmonary disorders, the mortality, and the deformity itself. And when we look at it, we also know that some do become pain-free. The pain from the broken bone can settle down in about a third of them, but a third do become chronically painful, and we just don't know why. Is it because it's a true suit arthrosis? Is it because of the altered biomechanics and accelerated degenerative changes? Is it because of some metabolic bone disease that we just don't understand yet, like osteomalacia or some other reason? But I'd maintain to this audience, and we're all spine practitioners, we all know about this, not one of these ever spontaneously regains height or sagittal alignment. Over the last 10 years, we've heard a lot more about the importance of lumbar lordosis. We know that life is a kyphosing event. That does not get better over time. And if you look through these things, the spinal deformity is correlated with impaired gait, with poor balance, as Gold and Sinaki told us. It is correlated with disability and reduced quality of life, as Leidig-Bruckner told us. It is correlated with reduced lung function. It is correlated with early satiety and gastric distress, increased fracture risk, and excess mortality. I'll say that again, and excess mortality. People do die because of this, because it is left untreated. And the most important thing is that the consequences are independent of the pain. They may be pain-free, but all these other things still happen. And that's why it's important to pay attention to these patients and to treat these patients. So if you don't believe it, here is a synopsis of the literature again. SF36 function scores unchanged at 2 years after vertebral compression fractures. VCF patients treated with non-surgical management did not show any improvement in pain and function compared to the treated or the kyphoplasty patients. Worse SF36 outcome scores in hip fracture than in hip fracture patients at 2 years and 5 years. As orthopedists, we've done a great job taking care of hip fractures, but we've not done a good job, and we've got objective outcome evidence that says these patients are actually worse. And the mortality is greater at 4 to 5 years in this group, and we know that these are not stable. They may not always be apparent on the initial x-ray, and the collapse can be slow and progressive. So we do have to pay much more attention. This is going to be a big problem in our practice, especially deformity practices, individuals that are seeing, because we're seeing many more 65, 70-year-olds with these degenerative, potentially on top of idiopathic or de novo fracture curves that then present with a new osteoporotic compression fracture above or in the curve, and how do we go about treating that? So in orthopedics, we would really never dream of leaving a hip fracture untreated, a wrist fracture untreated, or an ankle fracture in a biomechanically or physiologically compromised position. So why were we so ingrained to leave the spine as it is? Essentially because we didn't have good treatment options. But now we've got some treatment options. We do know better. We understand the biomechanics. We understand the importance of deformity. We understand more about bone physiology. So we can treat these patients, and we can treat them medically with the appropriate anti-osteoporosis type medications. We can treat them non-medically with the various rehab physical therapy programs, and we can now treat them surgically much more appropriately. So when we're talking about vertebral compression fractures, my premise is it's about biomechanics. That's what we are looking at. We want to make sure the spine is tall, straight, and functional. If we load the spine, we know that the load transfer goes through the centrum of the spine, and then down a little bit, or 80% goes through the centrum, about 20% around the body of the spine through the cortical shell, and then down to the vertebral body below. If you've got an osteoporotic bone, the load transfer only minimally goes through the center because there's no substrate there to transfer it. The majority of the load goes through the shell now. The shell becomes insufficient, it's still transferred below, and that's what generates further fractures. And if you look at the spine, it's much like the Leaning Tower of Pisa. You've got a crack in the middle, the crack progresses, the lever arm is accentuated, you do have force concentration at the index vertebral body, and eventually the superior vertebral body abuts on the inferior, which then again exaggerates it. So kyphosis begets further kyphosis. So when we're looking at vertebral augmentation, what are the indications? Patients with progressive and painful osteoporotic or osteolytic wedge compression fractures, either due to primary, secondary osteoporosis, myeloma, or other lytic type metastases. Patient selection is clearly important. This is a 29-year young male who fell 30 feet. He sustained this burst type injury. He was seen in an emergency department and had an operation. Here's his scan. Here is the operation he had. We did not do him any good. We didn't pay attention to the indications. This is not an osteoporotic fracture. Now this guy is worse off. But now I want you to look at this film here and his vertebral body there, and look at this film here. Here he is when he shows up in my office 6 months later, essentially paralyzed. The surgeon realized that this was an issue initially, did an immediate laminectomy, didn't really get much cement out. But look what's happened to the bone here versus the bone here. Injecting this cement, I think, predisposed this individual to essentially a compartment syndrome or avascular necrosis of this bone. Now he is much worse off than what he was before. So you can see we really have to pay attention to the indications to what we're doing when we're talking about vertebral augmentation. So this is a spectrum. We have a spectrum from vertebroplasty to kyphoplasty. And I like to keep it as generic terms as possible. If we want to stabilize a segment, we may want to do a vertebroplasty technique, which is just an injection. If we have to reduce or reconstruct, we may want to use the kyphoplasty techniques. And right now there's about a dozen different toolkits, tool sets that are out there that can help us do this type of thing. So I'd implore you all to not consider it one versus the other. Think of the compression fracture, think of the biomechanics, think of the patient, and then use the right tool for the right reason. Vertebroplasty has been around for an awful long time, first started in France. Curiously enough, the first recorded, quote, vertebral body injection was an open procedure into the C2 body for a hemangioma. And that's where all of this came from. And now we've been doing it quite regularly, and under the right indications, I think it's a very, very good operation. Kyphoplasty is an evolution where we're using tools to manipulate bone, to realign the spine, and essentially to create a cavity to fill with some kind of bone filler, be it cement, be it a synthetic, whatever the flavor of the day may be. So those are the spectrum of things that we can do. But there are a number of issues, and this is a slide that I've been using for the last 10 years at least, looking at this stuff, where we've got the indications. Is it pain or deformity? I think, you know, my bias now is deformity. As a deformity surgeon, I look at the spine, and the issue we're really treating is the deformity. And I think all of us agree, yeah, a lot of these patients do become pain-free. The timing, when do you treat these patients? Well, if you know that the Leaning Tower of Pisa is going to fall over, why let it fall over? Bolster it up, hold it up there, treat them medically, treat them appropriately as you can surgically. The biomechanics and the method of reduction. How are we going to do this in the least invasive and most appropriate fashion? There are a lot of people working on this right now. The number of levels that we can treat at one sitting. There have been issues with methylmethacrylate injection. The free monomer can get into the circulation. It is arrhythmogenic. It does induce hypotension. We have to understand the physiology of what we're doing. The approach, there are many approaches. The patient diagnosis, what are we treating? Osteoporosis is the mainstay for this, but tumor is a huge population of patients. The oncologists are doing a wonderful job keeping patients alive longer, but we know the tumor itself, the cancer itself, and the treatments, the chemotherapies and the radiation therapies do destroy bone. So these patients are going to run into problems. So that's another group where I think this technology, vertebral augmentation, is going to be very, very valuable. And then what void filler do we use? Cement is our friend. We've been using cement, methylmethacrylate, for well over 70 years right now in various applications. We know its biomechanics, we know its limitations, and with the healthcare reforms around us right now, it is inexpensive. And it's hard to justify using one of the bone substitutes at $2,000 a pop in an 85-year-old individual when we can use a bag of cement at $100 a pop in that same individual. So we've got to look at all of these factors when we're treating these patients. So I would submit that in vertebral augmentation, the decision is far more important than the incision. Thank you very much.
Well, nothing destroys confidence like follow-up, and so what we're going to talk about now is I think anyone who says they don't have complications doesn't actually do the procedure. I'm certainly not going to say that Mike's going to bring his own label of complications, but he's going to review complications in these procedures to give us a full spectrum of understanding. Mike Lee.
Thanks, Randy. And good morning. So complications in vertebral augmentation. So vertebroplasty and kyphoplasty have both been shown to provide symptomatic relief for vertebral compression fractures. Now, this last statement has recently been challenged in the literature by a study by columnist and also Dr. Jerry Jarvik, who hopefully will speak on this. And hopefully we'll see some healthy debate between the two and some healthy exchange regarding different ideas of the clinical effectiveness of these procedures. But that's not the purpose of this talk. This talk is specifically to talk about complications and safety. So we all know what vertebroplasty and kyphoplasty is by now. The short message is that complications are rare, but as we all know, potentially devastating. And this devastation can occur likely because of the extravasation of cement, which can either cause neurological injury, cement embolism, and has recently been implicated in the occurrence of a new fracture. So there are literally dozens of case series out there in the literature looking at vertebroplasty and kyphoplasty. Most of these are retrospective. There are some prospective case series out there, and there are even fewer prospective comparative studies. The weakness of these prospective studies is that the power is really too insufficient, or so insufficient that you can't glean any really meaningful conclusions. So methodologically, that kind of leads us down the path of pooling data or meta-analysis or systematic review. This is the one that I happen to be most familiar with and the most recent one to my knowledge. And in this one, we looked at medical complications, procedural complications, new fractures, and cement leaks by pooling the data that's out there in the literature. So procedure-related complications, we define these as things like cement embolism, neurologic deficit, fractures, discitis, dural tear, worse pain, and hematoma. Medical complications included things like non-cement embolism, respiratory insufficiency, cardiovascular complications, etc. Cement leak, we looked at both symptomatic cement leaks and asymptomatic cement leaks. And finally, we tried to make some sense of the idea of this new fracture as a potentially being associated with these percutaneous cement augmentation procedures. We looked at the data two different ways. One is by just looking at all studies and pulling the data from all the studies. And the second way, we only pull data from the prospective studies in an attempt to gain higher quality data, or look at higher quality data. So there are 121 reports at the time of this analysis looking at complications, and 29 of them were prospective. So what do we find? So medical complications per patient. When we looked at all the studies, it looked like kyphoplasty had a significantly higher rate of medical complications than vertebroplasty. But when we looked at only the prospective studies, this difference was not statistically significant. Furthermore, the mortality rate has been reported to be 0.6 to 1.0%, which is really not insignificant. And it's truly a testament to the patient population that's being treated here, the elderly with multiple medical comorbidities. So how can we explain this? Well, all this has to be taken into historical context. Initially, kyphoplasty was only made available to surgeons, and anecdotally, surgeons were more likely to use general anesthetic, which may have predisposed to higher medical complication. There also might be reporting bias, as many surgeons tended to admit these patients overnight rather than do an outpatient procedure. But on the whole, these procedures are similar enough that intuitively it seems reasonable that the medical complication rate ought to be comparable for both these procedures. What about procedure-related complications? Again, things like fractured pedicles, cement embolism. And looking at all studies, vertebroplasty had a significantly higher rate of procedure-related complications, not only in all studies, but also in the prospective study group. But again, this has to be taken in historical context. So vertebroplasty came into existence before kyphoplasty, and a lot of this might just be learning curve related. Realistically, the actual procedures are very similar, so to conclude that one procedure has a higher procedure-related complication rate over the other doesn't seem to make much sense, and it seems that a lot of these differences might just be learning curve related. What about new fracture? How often do we see this? Patient with an L3 compression fracture treated with cement. Before we know it, they've got an L2 compression fracture, and that fracture is treated with cement. So how often does this happen? Does percutaneous cement augmentation predispose to a new fracture? When looking at all studies, it appeared that kyphoplasty had a lower rate of additional fracture. But when looking at the prospective studies, this difference really was not statistically significant. We also looked at the distribution, trying to determine if adjacent level fractures were more predisposed with one procedure over the other. And with kyphoplasty, about 75% of these new fractures were at the adjacent level, whereas with vertebroplasty, it was about 50-50, and this difference was statistically significant. I will add to this that the numbers went down significantly when we're looking at fractures, so I would encourage you all to interpret these data with a grain of salt. So how can we explain that? A 75% adjacent segment fracture rate with kyphoplasty as opposed to vertebroplasty? Well, theoretically, we inject more cement with kyphoplasty than with vertebroplasty. More cement might be associated with a more rigid segmental construct. Does that yield to higher junctional stresses, and does that result in higher likelihood of adjacent segment fractures? Well, it certainly seems reasonable, but the etiology of these fractures are truly multifactorial, and we know that people who aren't treated will also have additional compression fractures. So how can we truly conclude that the procedure is associated with the onset of new fracture, though there is a lot of investigation in this area currently. Finally, let's look at cement leaks. So looking at asymptomatic cement leaks, vertebroplasty had a substantially higher rate of asymptomatic cement leak as compared to kyphoplasty, 43% versus 8.8% in all studies and 38% versus 8% in the prospective studies. When we looked at symptomatic cement leaks, again, significant difference, significantly higher for vertebroplasty as compared to kyphoplasty, 1% versus 0.4% and 0.5% versus 0%. And this might actually be due to some subtle differences within the procedure. initially, vertebroplasty was described as a high-pressure injection of a less viscous cement. The whole idea was that we wanted the cement to infiltrate the trabecula of the bone to provide stability. Kyphoplasty, as we all know, involves the inflation of a balloon, creating a void and filling that void with a more viscous cement. So it seems that the more viscous a cement is, the less likelihood there is of extravasation. This might be the explanation for this difference that we saw in this analysis. And this is consistent with the other two meta-analyses out there that I'm aware of. So complications from vertebroplasty and kyphoplasty overall are pretty rare, but they are potentially devastating. And all you have to do is just look up some case reports from the literature. This is an example of inferior vena cava syndrome following percutaneous vertebroplasty with polymethylmethacrylate. Here you can see a patient with multiple level cement augmentation. You can start to see the cement extravasation into the vena cava. They got a CT on this patient. You can see, well, if it's starting to look like a little bit like a venogram, well, that's because it kind of is. Instead of cement, or instead of contrast dye, you have contrast cement. This patient ultimately presented because of a swollen left leg because of partial occlusion of the vena cava and the iliac vein. This is an example of a delayed presentation of pulmonary methylmethacrylate emboli after percutaneous vertebroplasty. And cement embolism to lungs is kind of a scary thing because we don't really have a great way of treating it. Just supportive care, and that's about it. This doesn't really project very well, but you can actually see lines of cement in the veins within the lung fields. An intraatrial thrombus and pulmonary thromboembolism as a late complication of percutaneous vertebroplasty. So this is a patient. According to the caption, this white line here represents the vein, the hepatic vein, which supposedly directly communicates with the heart, according to this caption. When they took this out operatively, they extracted this cement spear, which essentially conformed to the shape of the vein, making a little toothpick. This toothpick became the nidus of a fairly large thrombus, which they extracted from the heart. So you can see there are major complications that can occur from cement embolizing to various parts of the body. This is kind of a scary complication, multiple cardiac perforations. So this is a picture of the heart, and I'm not entirely certain on the orientation, but you can see this toothpick-like cement stick spearing the heart in multiple places. So it's not just a matter of thrombus formation or direct occlusion of vessels. These things can actually pierce organs within the body. That's kind of a frightening complication from vertebroplasty or kyphoplasty. Again, another picture of the same thing. There's another example of a cardiac perforation and tricuspid regurgitation. This is a CT scan. Here, again, you can see the cement. And again, picture of the heart with the cement toothpick just literally piercing the heart in multiple places. So these are kind of frightening complications. And finally, as spine surgeons, one of our largest fears is going back into the canal. This is a case of a patient who had two-level cement augmentation. And you can kind of see some concerning radiographic features here when they got a CT scan. If you're wondering if this is a CT myelogram, well, it kind of is. Instead of contrast dye, it's contrast cement intradurally. And needless to say, this patient did fairly poorly. So on the whole, vertebroplasty appears to be associated with a higher cement leak rate, both asymptomatic and symptomatic. Future prospective studies are always needed to further evaluate. But the bottom line is complications from cement augmentation are fairly rare, but they do have the potential to be devastating. Thanks.
Well, I'm going to present now Jerry Jarvik, whose name you've probably recognized from recent literature, one of the primary authors and one of the two recently published prospective randomized controlled trials of vertebroplasty. As I said before, nothing destroys confidence like follow-up, and herein the value of randomized controlled trials. I think what we need to listen very carefully is to how well the study was done, what the results were, and then think about what it means to your practice. Jerry?
Thanks very much, Randy. Well, we embarked on this back in, well, we actually started in 2003. And this was an article that was published in the New York Times by Gina Colada, which was essentially a case study for futility of doing randomized trials. At that time, when this was published, after we'd been going for over a year, we'd only enrolled 2 subjects into the study. So clearly we were failing and had to do something radical. We did. We changed a variety of procedures. We went out of country, which was a key aspect of the study. So Australia and the UK were key recruitment sites for our study. And we actually were able to accomplish and eventually publish in the New England Journal this randomized trial of vertebroplasty. Now, I should say that this was published alongside a manuscript from a group in Australia which had a very similar design to our trial. So it was a randomized controlled intervention, and the control intervention was very similar to ours. And in fact, up front, we spoke with the Australian group and agreed to similar metrics. And so at the end of the day, we're able to really compare our studies to theirs. And these were the first two large randomized trials addressing this issue of vertebroplasty. And as many of you probably know, our results were that patients undergoing vertebroplasty improved, and moreover, the improvement was similar to other studies that have been published in the literature, either non-controlled case series or controlled cohort studies, of which there were 2 at the time. But that the control group improved to a similar extent as the vertebroplasty group. And of course, this was a big surprise to a lot of people, including us. And moreover, this independent study from Australia arrived at nearly identical conclusions to ours. Our primary outcome measure was the Rowland score, which you've heard about. It's a functional disability score focused on patients with low back pain. And you can see our Rowland disability questionnaires at baseline were sort of in the 17 to 18 range, which are quite high. These patients are fairly disabled from their back pain. And both groups improved. Our primary endpoint was 1 month. After 1 month, we allowed patients to cross over to the alternate intervention. So if they'd gotten the vertebroplasty, they could get the control. If they'd gotten the control, they could get the vertebroplasty. And patients did cross both ways, although more crossed from the control to the vertebroplasty, which I'll talk about in a little bit. But no difference in the Rowland score. We also had pain visual analog scale as our co-primary outcome, and no difference between the two groups at either 3 days, 2 weeks, 1 month for these outcomes. And then we looked at a host of other outcomes, including the SF-36. We looked at medication use. We looked at the EQ-5D, which is the Euroqual, another general health-related quality of life measure. And really similar outcomes across the board, except interestingly enough, opiate use was slightly higher in the vertebroplasty group at 1 month. So we've gotten a little bit of response about this article after we published it. And there's, of course, still a strong feeling that vertebral augmentation actually improves pain and function in patients. So clearly, we must have done something egregiously wrong. And the criticisms listed here are a few of the major ones. Our subjects were not representative of the vertebroplasty populations. Our patients didn't have enough pain. Their pain wasn't really severe enough compared to the patients that actually get treated. Or our patients had too much pain, and you, of course, wouldn't expect them to get as better as the ones that are being treated. The fractures were too old. We weren't actually treating acute fractures, or that we enrolled too few subjects, and that's why we weren't able to demonstrate a difference, and so we were underpowered. So regarding sample size and our power, when we first designed the study, sample size, we took a lot of pains to make sure that we were adequately powered. Originally, our sample size, we were hoping to get 250 subjects into the study, which would give us an 80% power to detect relatively small differences. So on the Rowland scale, to detect a 2.5-point difference and a 1-point difference on the pain scale. These are generally smaller than what are considered minimal clinically important differences on these scales. The Rowland scale is probably a 2 to 3-point difference as a minimally clinically important difference. And the pain scale, generally people are actually now going to a % change in pain compared to baseline, so around a 30% improvement in pain, something like that. The problems that we faced in recruitment are similar to other randomized trials of both surgical and non-surgical interventions. We initially overestimated the recruitment rates that we could get in the US. In Australia, when we started the study, the government did not pay for vertebroplasty, and that changed in the middle of the study. So that hurt recruitment. We didn't account for initial regulatory obstacles with the FDA. So there was a planned interim analysis by the DSMB. We revised our target to 130, which still gave us about 80% power to detect a slightly higher difference, a larger difference in the Rowland scale, and a slightly higher difference in the pain difference. But the bottom line is, at the end of the day, with our 131 patients that we enrolled, we were not underpowered to detect clinically important differences. So only a tiny fraction of screened patients enrolled. This is a problem that's common to RCTs. Again, it's this rigor versus relevance dichotomy that you have to face. Our results couldn't possibly be valid, and that was the flow chart of our patients. We initially assessed over 1,800 patients, and we excluded over 1,600. Now, that's a huge chunk of people. However, most of these patients are not ones we would have wanted to include in our study. These were the leading causes of exclusions. We didn't want to look at tumors. We didn't want to look at people that didn't have fractures and so on. There were 300 people that declined to participate, and that's sort of the key group, you know, the ones that were eligible that decided not to participate in the study. So we got 131 of that 431 enrolled. That's 30% success rate. This is actually good for RCTs of invasive interventions. You compare it with a sport trial where they enrolled 25% of eligible patients. And we had a few measures to look at those who were enrolled versus those that weren't. There were no significant differences between those that did and didn't enroll in the study. So we excluded inpatients. We've been criticized for not including inpatients. Most vertebroplasties occur in outpatients nowadays. We didn't enroll patients with severe enough pain. In fact, the average pain at our leading site was around 7.5 on a 0 to 10 scale. And when we compared it to the pain scores in those that didn't enroll, so eligible but that didn't enroll, you know, unfortunately the questions were asked slightly differently, but again, pain scores were actually comparable. And then you look at our pain scores compared to what else is there in the literature, and Wardlaw, which was the free trial that was published in Lancet, had fairly comparable or nearly identical pain scores at onset, and we're sort of right in the middle of pain scores compared to what's out there in the literature. Patients with severe pain didn't enroll. Well, we actually looked at patients with our baseline pain scores greater than 8, and it didn't really change the conclusions at all. So whether you're looking at the patients with the most severe pain scores or the less severe pain scores, the difference between the control and the vertebroplasty was no different. And then finally, we didn't have acute fractures. We, in fact, did have a fair number of patients who did have acute fractures less than 6 weeks compared to more than 6 weeks in our cohort. And again, there was really no difference in response. We actually had excellent follow-up. Here we go. 98% at 1 month adhered to the treatment assignment, and we had virtually no crossover prior to 1 month. We had a lot of crossover after 1 month. So there was one outcome which had a P of 0.06 in our paper, which was % achieving this minimal clinically important difference in pain reduction. It's important to remember this was not a pre-specified outcome, not a pre-specified primary outcome. There's a potential problem with multiple comparisons, and in the same group, there was no difference in the Rowland score. So that's, you know, it's interesting to note, potentially could merit further investigation. This issue of crossover, I think, is a key issue to talk about and to think about. As I said, there was essentially no crossover prior to our primary outcome at 1 month. It's important to remember that crossover was not an outcome, but it was really a tool to enhance recruitment. So in order to convince patients that they should enroll in the trial, we could essentially tell them that after 1 month, if you haven't got better, you will get the other treatment, whatever that treatment was. Crossover varied substantially by site, and so it's probably not only patient factors that influence crossover, but also physician and institutional factors. And this, I think, is one of the most fascinating graphs that came out of our study. which essentially showed that it's not what procedure you got that really mattered as to whether you got better or not, but it's whether you adhered to that assignment at baseline. So those that were assigned to the control group and adhered and assigned to the vertebroplasty and adhered initially did better and stayed better. Whereas if you didn't get better with that initial treatment, whatever it was, vertebroplasty or the control, then if you crossed over, you didn't really improve very much. Sort of fascinating. So intention to treat analysis, which is really the only analysis, which means that you analyze the groups according to which patients were initially assigned, is the only analysis that preserves the randomization. And the important thing about randomization is it controls for all confounders, even ones that you don't know about. So it takes care of bias that you don't know about. It attenuates the effect size, but of course this may mimic true practice. People bring up the issue of subgroup analysis, and there may well in fact be subgroups that derive a greater benefit from vertebroplasty than the control intervention. But remember that if you postulate that there's a subgroup which is doing better, then there's another subgroup which is going to be doing worse to give you the average effects of your trial. So be careful before you go down that road too far. And any subgroup analysis from a study like this can really only be hypothesis generating. There's a great quote, which the answer to an RCT that doesn't confirm one's belief is not the conduct of several subgroup analyses until one can see what one believes. Rather, the answer is to re-examine one's beliefs fully. So that's not the end of the story, of course. Vertos 2, another randomized trial that was recently published in The Lancet. Now, this was a randomized trial of vertebroplasty from a European group, a Dutch group, but it wasn't a blinded trial. Their results were quite different from the Australian study and the INVEST trial. There was no blinding, as I said. They essentially, the design was vertebroplasty versus usual care. And so they couldn't blind patients. They could have actually blinded the outcome assessors, the people that were asking patients about outcomes, but they didn't. And they showed that both groups had some improvement, but that the vertebroplasty group had a greater improvement than the control group. And then we can speculate about why the difference. The amazing thing about the Vertos 2 study, and this just came out last week in AJNR, 25% of their patients had asymptomatic cement emboli. 25%. I just found this astounding. They systematically did chest CTs on these people. Now, whether that impacts on pulmonary function, whether that will have subsequent consequences down the road, I think is an open question, but just something I think to give you pause. And then finally, the power of anecdote. We've talked about RCTs and evidence-based medicine. So here's, I don't have a patient to bring in, but being a radiologist, I can bring in some films. Here's an MR. Which was an elderly woman who had an acute fracture. You can see the vertebral body's normal marrow signal is almost nearly completely replaced by the edema. And this was prior to entering into the study, so she got a vertebroplasty, had a great response, and then had another fracture at an adjacent level. And this was when the study was ongoing. And she was willing to be randomized, even though that she even though she'd had the procedure and had a wonderful response, and so was enrolled, blinded, got the procedure, and had a great response the second time, and this was the procedure that she had the second time. So I just want to leave you with the thought that RCTs are an important component. They don't tell the whole story. You can't get at rare outcomes. It's hard to do good subgroup analysis. But they play a critical role in our understanding of whether something actually works or not. Thanks for your attention.
We're going to finish this session with Izzy coming back and talking about vertebroplasty versus kyphoplasty.
I've been challenged to talk about vertebroplasty versus kyphoplasty. If we go to the literature, You use PubMed, vertebroplasty and kyphoplasty. The first article showed up in March 1985 for vertebroplasty. The first kyphoplasty was April 1998. Since then, there have been 1,783 papers published from 1985 to 2010. On average, that's 6 papers per month. A lot of people are thinking about this, which I think is a wonderful thing. We're being critical. We want to find out what the right answer is. We just haven't been able to really figure it out. I must admit, I've tried 5 times now, unsuccessfully, to get a randomized controlled trial of vertebral augmentation versus non-operative care. Some of you in the room have been involved in the same trials that I've tried, that I've been involved with to set up. It is a difficult, difficult task. Interestingly enough, in Europe and Asia, they have been able to do that. And there is some evidence that has come out of there. And there'll be a little bit of repetition here with what Dr. Jarvik had presented, but we'll see. So this is a first study, Wardlaw's study, published in The Lancet, March 2009. The free study was a randomized controlled trial, 300 patients, 1 to 3 VCFs, non-surgical management versus kyphoplasty. And they had all the typical outcome scores. A number of individuals have critiqued this study, have looked at it, and essentially it's been labeled as level 1 evidence validating the benefits of kyphoplasty early in the treatment paradigm of vertebral compression fractures. And one of their conclusions was for acute VCFs, kyphoplasty is more effective than non-surgical care, and there was no difference in the frequency of adverse events between non-surgical care and kyphoplasty. The next article is the one that we've heard an awful lot about already, the randomized trial of vertebroplasty for osteoporotic spinal fractures. Another study that we've tried to get going is one looking at myeloma. And again, we've been hampered by various regulatory hurdles, funding hurdles, granting hurdles, and it's just so difficult to really do this. This is an adequate study. I'm not convinced it is the study. And I must admit, my biggest issue is the, quote, sham procedure. And Dr. Jarvik had pointed out that it is still a procedure. You were injecting some medication in there, and you're seeing what's going on. So I don't think we can generalize the results of this to non-operative care. And what I would have personally liked to have seen is non-operative care versus vertebral augmentation, vertebroplasty. And we'll get to that in a minute. But again, their conclusions, as you've already heard, improvements in pain and pain-related disability associated with compression fractures in patients treated with vertebroplasty were similar to the improvements in their control group out to 1 month. And I don't think any one of us can argue with the results. The results are what they are. It's our interpretation of the results that we can really argue with. This is the second trial. Also in the New England Journal of Medicine, published tandem with the previous trial. Bookbinder was the lead author on this, the randomized trial of vertebroplasty for painful osteoporotic vertebral fractures. 78 patients, kind of a small study, 4 centers, vertebroplasty versus sham, 6-month follow-up. Again, a similar study with a sham procedure with some local anesthetic injected there. Again, it's not really a sham as far as I would consider, because you're doing something, you're intervening, you're injecting something in there. And their conclusion was they found no beneficial effect of vertebroplasty as compared with a sham procedure in patients with painful osteoporotic compression fractures at 1 week, 1, 3, or 6 months after treatment. The critiques of all of this, not a sham procedure. Follow-up, too short. Enrollment too long and or abandoned, the crossover issue that we've heard already about, and both studies underpowered to validate their primary endpoints. Now again, I'm not a statistician or an epidemiologist. These are the things that I read and I pick up from all the various commentaries, but there are criticisms against this, as there are criticisms against all the others, and it boils down to really an interpretation. Which expert are you going to believe? Now here's the Claisen study, and this is the one that Dr. Jarvik had mentioned as well, vertebroplasty versus conservative treatment in acute osteoporotic compression fractures, the VERTOS 2 trial. I was involved with the VERTOS 1 trial. This is the Vertas 2 trial, published in The Lancet. The Wardlaw paper, published in The Lancet. Bookbinder and Calme's papers, published in New England Journal of Medicine. Is there a theme here? Stick with me on this one. But this was an open-label, prospective, randomized trial in patients greater than 50 years. Again, as a simple bone setter, this is what I'm doing with these patients. I'm not going to take this patient to the operating room and put a needle and inject local anesthetics. If I'm taking them to the operating room, I'm going to do something, or I'm going to treat them with an exercise program, medications, and anti-resorptive medications. So for me as a practicing practitioner, this study has more merit in my mind. And then a good number of patients, well-enrolled, government study, well-documented when you read through it. And their conclusion, in patients with acute vertebral compression fractures and persistent pain, vertebroplasty is effective and safe. Pain relief after vertebroplasty is immediate, is sustained for at least a year, and is significantly greater than that achieved with conservative treatment and, for the health reformists, at an acceptable cost. So they've got it. So I think this really comes out and gives us a little more practical information that we can use on a day-to-day basis. Now, 97% of you felt that vertebral augmentation is still a good tool, and I think we can take a study like this that has been critiqued and is being labeled as a level 1 study and say, yeah, we are doing the right thing in treating these patients. So to summarize the literature, and clearly I'm not going to go through the 1,783 other papers. These are the 4, I think, principal papers that we have now. Vertebral compression fractures do have a significant impact on the quality of life. The outcome of the balloon kyphoplasty studies show improvement compared to non-surgical management. The outcomes of the controlled vertebroplasty studies are mixed and I think are based on interpretation. You can't take the sham procedure and compare that to non-operative. Ideally, we need a third arm in one of Kalmaz's bookbinder's study, and I'd love to hear your comments on that when we discuss this. I do feel that vertebroplasty and kyphoplasty are different tools. You've got a hammer and a screwdriver in your toolbox. You're not going to use the screwdriver to pound in a nail. You've got to decide on using the right tool for the right reason, and I don't think that the results are generalizable. There is a lot of evidence that supports the safety and effectiveness of both vertebroplasty and kyphoplasty, but as always, there's a lot of unanswered questions, and we do need to study this more, and I'm glad to see that there is still interest and people are still looking at this critically. So back to the Lancet versus the New England Journal of Medicine. New England Journal of Medicine has published 2 negative vertebroplasty papers. The Lancet has published 2 positive papers, one on kyphoplasty, one on vertebral augmentation. I'd like to think that the reviewer groups are similar, the standards of publications are similar, but I've had the privilege of listening to the chief editor of the Lancet on one venue and the chief editor of the New England Journal of Medicine at another venue. And maybe I'm reading between the lines, but I don't think they like each other. And I think there's something going on here. So just keep that in mind when we see these trends. We talk about biases and conflict of interest. Is there something going on here between the Lancet and the New England Journal? And all the other papers on vertebral augmentation are published in radiology journals, spine journals, orthopedic journals, neurosurgical journals. Why did these 4 papers get lumped into one of 2, and how did we get such an even split on that? Just questions to think about. So vertebral augmentation, from vertebroplasty to kyphoplasty, we know we get good pain relief. There's good functional outcomes, short hospital stays, rare complications, as Dr. Lee had pointed out to us. The risks are minimal for both, but the consequences can be substantial. And this is where I think if you're a spine practitioner and you understand how to get into trouble and how to get out of trouble, then you should be using one of these tools as you see appropriate according to the indications for your patient. If, on the other hand, you're not a spine practitioner, and unfortunately, in some of the areas that I've worked, there are individuals who are stretching their limitations and trying to do these procedures when they should not be. So the last two things I want to talk about is the American Academy of Orthopedic Surgeons. I'm proud to be a member of the American Academy of Orthopedic Surgeons, but I must admit I am rather disturbed by this guideline that was just released this week. I know a lot of the members on that panel. I know a lot of you in the room know the members on that panel. They produced this guideline with 14 essentially statements. 3 of those statements are positive statements. Every other one of those statements says inconclusive evidence, can't provide a guideline, insufficient literature, et cetera, looking at various aspects of osteoporosis and vertebral augmentation. So the recommendations are all over the board on this. But they did provide 3 recommendations, one of which was that for an L2 or L3 compression fracture, an L2 selective nerve root block is an appropriate treatment. Now, I have no idea why they would even come out with that. There's one paper that shows with a couple patients where someone treated a compression fracture with a nerve root block and they felt that that was worthy of a recommendation. This is recommendation number 9. Kyphoplasty is an option for patients who present with an osteoporotic spinal compression fracture on imaging with correlating clinical signs and symptoms who are neurologically intact. And they felt that there was good level 2 evidence, and they based that on the Wardlaw study primarily, and they felt that the strength of this recommendation was weak. Recommendation 8, on the other hand, was we recommend against vertebroplasty for patients who present with an osteoporotic spinal compression fracture on imaging with correlating clinical signs and symptoms who are neurologically intact. They felt there are 2 level 1 studies and 3 level 2 studies and felt that there was strong evidence to support the recommendation against vertebroplasty. So it does boil down to interpretation. This is a group of experts that interpreted it one way. We've got individuals in here that are going to interpret it another way. 97% of us felt that vertebral augmentation is still an important tool. I still feel it does despite these guidelines, but we absolutely know what's going to happen with these guidelines. The insurance companies are going to grab it, and we are going to be denying our vertebral compression fracture patients potentially important and valuable treatment. So with that, mistakes. It hurts to admit when you've made a mistake. However, when the error is big enough, the pain only lasts a few seconds. Thank you very much.
Well, we have a few minutes for discussion and question and answer. I'd like to kick it off actually with a statement that I think is important, and that's that when you come with level 1 evidence, you don't actually interpret it, you analyze it. And I think analyzing your study, Jerry, and also Buckbinder's study, you did not show that these procedures did not improve pain. Basically, what you actually showed, the question you actually asked was, does the injection of cement make a difference? So it's not really whether or not a procedure. So then comparing the Wardlaw paper to your paper is not incompatible. What you actually showed was that you could, if you chose, stop at the point of injecting cement and presumably get the same result. Is that not correct?
Yeah, no, I think that's essentially right. And well, but to go back to the issue of interpretation, you're always interpreting results. And I think Izzy is right. The data is put out there, but then people have to do something with that data, including patients, physicians, policymakers. Yeah. And so there's always going to be some sort of interpretation overlaid on the conclusions. I think the conclusions from our study and from Rochelle Bookbinder's study, the Australian study, are essentially cement does not seem to improve outcomes compared to, and again, not a sham, right, but another intervention. And that's actually an important point also, and something that we struggled with early on in our trial. We got away very quickly from calling it a placebo-controlled trial or a sham-controlled trial, which is different than the Australian group, who continued to call it a sham trial. And there were a number of reasons for that. One was for recruitment. Much easier to recruit patients into a trial where you're offering them another intervention that actually may improve outcome. And we were thoroughly convinced that it might improve outcome, just doing this local anesthetic injection. But then also for policy implications, And in this era of comparative effectiveness research, when you really want to do your research comparing one plausible intervention to another that can be used in medical practice, this is a potentially plausible intervention. A plausible alternative is this local anesthetic injection.
Ted?
Bob Campbell, Philadelphia. The public perception of scientific studies is extremely important, and we give it short shift. The abstract of Stu Weinstein's article in JAMA on untreated adolescent scoliosis is widely quoted by the media, Washington bureaucrats, and if you look at it, and Wally brought it up, 2/3 of the patients were missing, okay, and they quote a mortality rate. Now, I'm good friends with Stu Weinstein. He's a wonderful, wonderful contributor to our specialty, but he tells me no one moves from Iowa. So those 2/3 of the patients, they're probably dead. And your mortality rate looks really good if you exclude the dead patients. And I've spoken to a significant number of the patients, the survivors, had dyspnea at rest. And if you look carefully in the actual article, they chose not to do PFTs on these patients. They said they were studied 22 years previously and didn't feel it was worth repeating. Now, that's a serious lapse in logic there. So, you know, when a lot of people just look at abstracts, but, you know, to talk about these, really need to read the articles and point out the shortcomings. So, public perception, that decides everything. Washington watches that. Our patient watches that. If we don't do a better job of explaining ourselves and pointing out deficits or strong points, we're going to be in big trouble. Thanks.